So take your seats, please, so that we can start on time and finish on time. We'll study some cases having to do with vessel diseases. Now, this is our first case, and this is an incidental finding in the coronary artery of a young male who died in a motor vehicle accident. At the end of the lesson, please. You can sign at the end of the lesson. So, what can we see here? What is abnormal? You see some yellow staining material. And where is it located? It is located in the first layer of the artery, which is the intima. To be more precise, subintimal, below. And of course, what material is this? I'm sure you can recognize it's fat tissue, and it has to do with all those constituents of cholesterol which deposit in this area, in the intima of the vessels, and so the perfusion of nutrients is not proper to the other components of the vessel walls, and so the vessel wall becomes sclerotic. And this is probably the beginning of atherosclerosis, which is the main cause, not the only cause, the main cause of thickening of the wall of the vessel walls. So, as years would go by, most probably an atheromatous plaque with all its constituents would form in this coronary artery. And what could this cause to the patient? Since the formation of the atheroma somehow narrows the lumen, the perfusion of the myocardium will not be proper. And what will this cause on a chronic basis? On a chronic basis, myocytes would become, that's the abrupt. That would happen when we have a thrombus abruptly, acutely occluding the lumen of the coronary. Then the myocardial fibers would become necrotic, would have coagulative necrosis. But on a chronic base, atherosclerotic vessels give some symptoms not of acute ischemia, but of chronic ischemia, which is called, this is a sort of pain having to do with physical activity, which, as far as the myocardium is concerned, it is called angina. But the coronary arteries are not the only arteries involved by atherosclerosis. Other arteries of middle or large size are also affected. For example, think of a diabetic patient who has atherosclerotic plaques in the branches of celiac artery, having to giving the blood supply to the bowel. After a lunch, when a lot of blood needs to go there to the bowel so that digestion is accomplished, he will have pain. That would be abdominal angina. And think of arteries on the lower limbs. That means femoral artery or other arteries giving blood to the lower part of the leg. And when somebody walks, the muscles need more blood supply. If the artery is narrowed, pain will be caused. So the patient will have pain and he will stop so that the muscles won't need so much blood, and then the pain goes away. When he starts moving again, walking, the same problem appears and the pain comes again. So all these pains show us that the lumen of the arteries have somehow become narrow. However, in order to have necrosis, coagulative necrosis, an abrupt change must happen. Meaning what? A thrombus must be formed on the surface of the blood, and this abrupt occlusion of the lumen will cause infarct, an infarct, either a bowel infarct, a myocardium infarct, or any other, a renal infarct. So infarcts have a prerequisite of an abrupt occlusion in the artery's lumen. However, there are other signs which are not always evident. For example, coronary arteries which are responsible for myocardial infarcts most often do not narrow the coronary artery lumen more than 70%, because if they did so, angina would appear. So the patient would realize that he has a problem with his heart. When he would go upstairs, he would have a pain in his chest. However, these coronary arteries are very dangerous because an abrupt change may happen to the atheromatous plaque, and a thrombus is formed. So either the thrombus occludes the whole lumen of the coronary artery at this site that it was formed, or the blood takes him away, so he becomes an embolus and occludes a peripheral branch, a more peripheral branch of the artery. So have a look here. This is a medium-sized artery, and you see that the lumen is narrowed. Which layer is this? You see how it stains on eosine? This is the medium, this is the muscle layer, and this is the intima. These light staining regions within the intima is the lipoid tissue. And all this is the atheromatous plaque. However, the whole thickness of the intima is rarely involved. Most often, atherosclerosis is a segmental increase in the size of the intima. So you see here look here. This is the muscle layer, and this is the intima, and have a look here we are within the atheromatous plaque. You see how much the thickness of the intima has increased. So this increase is segmental. So it leaves a site which is between the atheromatous plaque and the normal thickness neighboring intima. This is a very sensitive site because there the blood, which is forced to pass from a narrowed lumen, has increased pressure. And if there is a site which received increased pressure of the circulating blood, because some degree of stenosis would appear. It is not enough to give angina. It is not enough to give an infarct. However, there is some sort of narrowing of the lumen. So in this part, that the atheromatous plaque goes to the neighboring normal thickness intima, then the blood has exerts a high pressure on this site, and so the endothelium is eroded. If we have an erosion or an ulceration, if it's of arteries of bigger size, what is formed there? If you have an erosion, what happens to this area, the area of erosion that the covering, the endothelium in this case, becomes eroded, becomes destroyed. What happens there in the erosion? Yes? Yes, inflammation, but inflammation is already there because the lipids that accumulate within the plaque are foreign bodies, so they cause inflammation. What abrupt change happens there when the covering of the intima, the endothelium, is destroyed.
The lipids will go into the bloodstream, the plaque and thrombus.
Yes, when some vessels break and we have hemorrhage within the atheromatous plaque. It either becomes too big, so it occludes the lumen, or what happens in an area of hemorrhage? Thrombus. A thrombus is formed, and that's we have the acute change of the atheromatic plaque, which causes the coagulative necrosis of the corresponding area of the myocardium. So you know the risk factors. Some of them we can change. Some of them we cannot change. And you can see all those diseases, hypertension, diabetes, hypercholesterolemia, which must be treated so that the atheromatous plaques do not become big. If they become big enough, they give symptoms of angina, as we said. However, it is not necessary to have a very big plaque so that it changes abruptly. Smaller plaques can also have this complication, which is very dangerous. Yes?
Confused as to how exactly the infarct is caused. So it's not by the specific atheroma, it's by the erosion of the...
Most common, yes. Having a thrombus formed in this area is the most common, but not the only cause of an infarct. Why? Because an embolus can come from the left ventricle, go to the aorta where the stones are, passes in, and there is no atheromatous plaque. Also, a patient with systemic lupus erythematosus, he has angiitis. So all this inflammation may cause an infarct in the coronary arteries. And another mechanism, which is not so well understood, is the vasoconstriction, the spasm of the coronary arteries, which has nothing to do with atheromatous plaques or inflammation. However, the most common cause is an abrupt change in an atheromatous plaque, which either increases its size abruptly, acutely, or is complicated by thrombus formation. And this causes the infarct.
But the atheroma itself doesn't leak into the bloodstream, the liquid.
No, it does not break.
Okay.
Its surface is eroded, and so a thrombus is formed there. Yes. So here we saw a medium-sized artery involved by atherosclerosis. Now have a look at this CT scan. Which organ is missing? Which organ is missing here? Yes, that's right. I think it's the left kidney. Why? Because there's no problem. No problem. You have the patient like you, and I do the scan. It's like you. So this is my right.
Yeah.
This is your
Left.
okay. So it's the left.
Yeah, but isn't this the,
Yes, but
this is the spine?
the head is
That's fine.
towards us.
No, he's like that. He's in front of you.
The head is supposed to be towards us.
He's in front of you. You can take the other stool and lie down. It won't change. It won't change our relationship. The patient is lying, and I'm in front of him. Okay? So this is my right part, this is your left. This is my right part.
Yes,
That's the right.
that's what I think.
I'm not thinking you are right.
Okay.
Can you explain that when we say to the left from the point of view of the physician?
You always refer to the patient's side, not to yours. What you see on the right, on your right, is the patient left.
Actually, it's the left, but it's not.
When you refer to a location, you always refer to the patient's location, not to yours.
Yes, of course.
Just a moment, we'll see it. Just.
We're getting confused because the spine is
spine is
here.
here, yes.
So it looks like if
Yes.
You are looking.
That's why I told you. You like.
there, I thought if
It's like I'm in front of you.
We thought we were looking like this.
No,
not from
no, you are not looking like this. No. So what can have, please, quiet please. What may have happened to this kidney in a patient having atherosclerosis? Something, an embolus occurred and it went down the branches of the aorta, went into the renal artery, abruptly occluded the artery, no blood to the kidney, and we had an infarct. And it was so extensive that the kidney was all necrotic. So it was removed. But what else do we see? Have a look here. Have a look here. This is the abdominal aorta. You see that it is very, very enlarged. And have a look here what it is filled with. This is a thrombus. It looks like soft tissue. The signal is similar to soft tissue. And sometimes we can see calcifications in the wall of the aorta. So this was a patient of a type 2 diabetes mellitus, had type 2 diabetes mellitus, and he had other symptoms, as we said, pains on the leg, and you see all these risk factors for atherosclerosis. And as we said, the left kidney is absent, all right? The left kidney is absent. No kidney here, no kidney here. When you have a CT scan, pay attention please, because this is very important. All right, we study the genes, we study mechanisms, molecular mechanisms, but first we must know where the patient is. So, he's in front of us, and he's lying. So, what is on my right? It's his left. Is that clear? In some examinations, radiologic examinations, that there is a different position of the patient, that's something else. In this case, is like a patient in front of us. He's lying, and he has the CT scan. So his left kidney is missing. Yes, please.
I didn't quite understand, why are the creatinine levels high?
Why?
Why are the creatinine levels high?
Yes. From the patient's history, we see that the creatinine level is raised. How do we judge the function of the kidney from the biochemical tests, the simple biochemical tests? We look at two things. One of them is creatinine, and when we have an increased level in properly hydrated patients, this is some sort of renal insufficiency. If the patient does not urinate, it's acute renal insufficiency. If it's on a chronic basis, it's chronic renal insufficiency. And by the way, the other marker is blood, urea, nitrogen. These two markers from the biochemical test show us how the kidneys function. So why is creatinine raised? Because the remaining kidney is hypoperfused because there is some sort of impairment, probably due to a generalized atherosclerosis, to the other kidneys vessels as well, not to the small vessels within the renal parenchyma, but to medium-sized vessels, such as the renal artery and its major branches, the ones that go from the renal, they go up from the renal pyramids to the cortex. I'm not sure of their name in English. They are intralobular, I think. They are called these arteries. There are the main branches of renal arteries. Yes. So here we had an enlarged aorta with a thrombus, complication of atherosclerosis. And here what we see, this is an aorta, extensively involved. What are you looking at? Let me have a look as well. Let me have a look. No problem.
We are still debating about that.
You're still... I know. It took me 30 years to understand, so it's no problem with you. No problem.
So interested.
But make sure that you understand it.
Yeah,
it's more important than you know the gene mechanisms.
Yeah.
More important if you have the patient in front of you. It's more important so as not to have an operation on the wrong organ.
You just got us right.
Okay? Yes. Because as you see, and I hope this continues during our lessons, which I think will be too many, either for good or for bad, I don't know. We'll be together for 2 months, 3 months. So we can communicate, because we are like a class. It's not like an impersonal relationship with students that you don't know their names, their faces. Here we'll be together 3 times a week. So we already know each other. So there's no problem, because there is no problem if you make a mistake, because I make mistakes. But I try not to repeat them. And if I make a mistake and you show me that I'm wrong, there's no problem, because that's the way I'll become better. If I think I know everything, that's why I always study, because what we are talking here is clinical medicine, as you've understood. Of course, we relate it to the pathologic lesions, but it's an introduction to what you are going to do from the next semester. That's why it is important to have a clinical context of the patient, not just theory. That's why we study cases. So if you don't understand something, feel free and tell me. Perhaps I don't know it either, but we'll look it up and we'll discover together what's going on. So you see here, that's the place of erosion, you see? And that's the place where a thrombus is formed, which can become an embolus, an embolism, can cause an embolism. You see, acutely thrombosed vessel, acutely thrombosed. And furthermore, a large artery or a small artery, not too small, of medium size, which is involved by atherosclerosis, since the constituents of the vessel wall are not properly, they do not take what they need to be, okay? The strength of the wall becomes weak. So the blood passes and it makes a sac. And most atherosclerotic vessels may be complicated by the formation of aneurysms. which is a very severe complication, because you see, if the aneurysm ruptures, the patient's blood will leave the vessels and the patient will die of shock. Okay, so the diameter of the aneurysm is of crucial importance. And as you can see, the diameter of 5 centimeters is very crucial in deciding whether the patient will have surgery for his aneurysm, or you'll just watch. You'll examine the patient to see if it grows, if its diameter increases, and then the patient goes to surgery. Here is an aneurysm. Can you identify which vessel this is? You see here, it's the bifurcation of the celiac artery. So can you tell me which that is? Yes, most probably it should be the iliac artery. And does it give a branch for the femoral after that? Okay. So what will this patient have with this image? What symptom is explained by this? A worsening right leg pain. You see here, this is the right side of the patient, okay? The right side, okay. And you see that the pulses are absent. Why are the pulses in his right leg absent? Because the blood stays in the aneurysm. And the peripheral tissues are not properly, there is not proper blood supply to them. So we have no pulse. You see a very increased cholesterol, very low HDL, so the LDL is significantly increased, which is not for good. Here was the aneurysm, and there are some cases of familial hypercholesterolemia, where there is a genetic basis. However, in these cases, the total cholesterol values is very, very increased, And you see some sorts of pain and claudication, and the danger of thrombosis is again very significant. Now, have a look here. Again, a patient with femoral and other problems in finding the pulse. Why? Because, as you can see here, there is an atherosclerotic aneurysm, and these are most probably some calcifications. Why? Because the aneurysm was formed on an atherosclerotic vessel, and when atherosclerosis increases in severity, calcium deposits are shown in the atheromatous plaque. And of course, since atherosclerosis weakens the wall, that's very, very dangerous, so that the aneurysm ruptures and we have the death of the patient. Have a look at this plaque. How is it different from the previous ones? Yes, please. Yes.
Can you explain the mechanism by which an atheroma can cause an aneurysm?
Yes. It's not so, I do not know exactly, but I know the principle, because in order that an aneurysm is formed, the wall must be weakened. So if it is not perfused with enough blood supply, because when we have the thickening of the intima, all the nutrients, it's not easy for them to reach the other layers. So they are not properly, they do not have the necessary nutrients from the blood to be strong. So the wall weakens, and we have an increased blood pressure at a local site because some degree of narrowing is evident. So the blood presses and the weakened wall makes a sac, and this is an aneurysm. Of course, on a local level, you may count metalloproteinases. That means matrix degrading enzymes, which are responsible. However, the basic concept is this. Yes. What has happened to this coronary? I can see that the lumen is completely blocked. All right? So this is the thrombus. This is the acute change of the atheromatous plaque. And here we can see, you see these needle-shaped structures. This is how we see cholesterol on tissues. These needle-shaped structures are cholesterol. And what else is there in the atheroma? Foamy macrophage, phagocytosing the LDL constituents, and when we have a persistent presence of macrophage, what factors do they secrete? What fibrogenic factors? So the other constituent of the atheroma is fibrous tissue. We have cholesterol crystals, macrophage, foamy macrophage, because they phagocytose lipids, and fibrous tissue. These are the main constituents of the atheroma. And sometimes some muscle cells from the media, from the muscle layer, go up as well and become part of the atheromatous plaque. So this patient had an acute myocardial infarction because that was a coronary artery that showed this acute thrombus formation. What happened to this bowel? And it's so black, it became necrotic. However, it's not like the myocardial infarct, which is pale in case blood does not reach the area. The renal infarct is pale because renal arteries are terminal. The myocardial infarct is almost always pale in case that blood has not come to the area. In this case, in the bowel, there are other circuits giving blood. So this adjacent blood supply is not enough to prevent the formation of the infarct. However, when the infarct is formed, some blood comes to the area. That's why it looks hemorrhagic. This is a hemorrhagic infarct. When do infarcts become hemorrhagic? When we have venous occlusion, abrupt occlusion, or when we have arteries abrupt occlusion. However, somehow blood from other areas come to the infarcted area. And this, of course, is evident in organs with dual vasculature, such as the lung, pulmonary artery, bronchial arteries, the liver, hepatic artery, portal, the portal vein, two sides of blood supply. So that was an infarct. And what's the problem here? The bowel will the abdomen will become distended, and if you leave the patient and not remove the necrotic segment of the bowel, what will happen? Sepsis, because the bowel of the necrotic bowel will rupture, and all the content will go to the peritoneal cavity, and the patient will become septic. Yes?
Why, even though we have blood supply to the area, is not sufficient to keep the cells alive there?
Because somehow more than 2/3 of the blood supply has been impeded. In such case, the adjacent routes of blood supply are not sufficient to make the bowel viable. Have a look, bless you. Have a look at these vessels. You see here that they are stenotic. However, atherosclerosis is not the only cause of stenosis in the vessel. Inflammation is another cause. And here we have autoimmune inflammation in the context of classic polyarteritis nodosa, which is an immune complex vasculitis. Have a look at the complications. Microaneurysm, similar to the atherosclerotic vessels. But here we have no atherosclerosis. We have lymphocytes invading the wall of the vessel. And an evidence of vasculitis is this homogenization of the vascular wall, which stains red with Mason trichrom stain, and this is called fibrinoid necrosis. All right? So this is, you see all the inflammatory cells. Can you identify them? Since it is immune inflammation, which inflammatory cells are expected to predominate? Lymphocytes, here they are. Mononuclear cells without significant amounts of cytoplasm. Here, how do we call this? This is another case of vasculitis. This is fibrinoid necrosis. However, there are other cells here as well. Which cell is this? Which we can see in its entirety and fragmented in the form of nuclear dust. Nuclear dust. Which cells are identified here? Which cells? There are some lymphocytes. However, I can see cells with lobulated nuclei. So, what are they? Neutrophils. And, of course, correlation with serologic markers is crucial for the diagnosis, because if the patient has these antibodies, that would be an ANCA-related vasculitis. If he had antinuclear antibodies, which disease is suspected with antinuclear antibodies? We'll study the same cases, hopefully, in the end of the semester when we'll have the polysystematic diseases. Yes? Lupus, most probably. All right? And that's a good diagnosis in case we have symptoms from the salivary glands and the conjunctivae. So this is ANCA vasculitis. The ANCA antibodies are found, and if the upper respiratory system is involved, we have granulomatosis with polyangiitis, formerly known as Wegener's disease. Other problems with the involved vessels. This is temporal arteritis. You see these giant cells which phagocytose the elastic, how is it called? Which divides the intima from the muscle. That's the elastic membrane. Giant cells go and eat the elastic membrane, the inner elastic membrane, but of course, since it is vasculitis, we see inflammatory cells in the intima of the vessel, and the result is the narrowing of the lumen. And since this disease, known as temporal or giant cell arteritis. Giant cells are not totally necessary for the diagnosis. However, they are quite often observed in tissue sections from these patients, since we have the external carotid arterial branches involved by this form of vasculitis. What is their a complication that may be most severe and dangerous for the patient. Think of the branches of the external carotid artery. And we have to give immunosuppressants, that means corticosteroids, so that the inflammatory infiltrate leaves and the vessel is saved from the inflammation. Which vessel is most important in the context that if it is involved by the immune inflammation, the patient will lose something very variable. The ophthalmic artery, yes, because if the ophthalmic artery is involved, he'll have vision problems. So that's why corticosteroids are necessary in this case. Here we come to small arteries of the kidney. These small arteries of the kidney parenchyma can become thickened mainly by two diseases: idiopathic hypertension and diabetes. And this material here is hyaline arteriosclerosis, not arteriosclerosis, because there are small arteries. They are arterioles. So this is hyaline arteriolosclerosis. And what will the results be? It's most common in diabetic patients and hypertensive patients. Then, when these small arteries are thickened, which part of the renal parenchyma is not properly, does not receive enough blood supply? Where do these small arteries lead to? They bring blood to the glomeruli. So the glomeruli become ischemic, so there is not enough urine produced, because if the glomeruli receive the correct amount of blood, they produce the urine. If they do not, they cannot produce the necessary amount of urine. So if the urine quantity is decreased, what is secreted from the juxtaglomerular apparatus? What is secreted? If there is not blood supply to the glomeruli, not enough urine is produced, so what is secreted by the renin, increased renin, so the system of renin-angiotensin II is activated, and we have another cause of hypertension. That means renal cause, a renal cause of hypertension. That's why most kidney diseases affecting the amount of the urine produced are possible causes of hypertension. So when you have a hypertensive patient, of course you may think that it's idiopathic. That's the majority of cases. However, you must check his kidneys. You must examine his kidneys, because perhaps there is a renal disease affecting the amount of the produced urine, so you have to know. Of course, you can have some signs from your blood urea, nitrogen, creatinine levels, but have a look, check the kidneys. Remember to check the kidneys as well. Here is another form of narrowing of the lumen due to hyperplasia. Hyperplasia. It looks like what happens in pulmonary hypertension to the capillaries of the lung circulation. However, I think this is a case of arteriolosclerosis. I think this is, again, it must be in the kidney, I think. Yes, kidney biopsy. Kidney biopsy. The vessels in pulmonary hypertension that we have already discussed are similar, very similar. This is hyperplastic. You see the smooth muscle cells being hyperplastic, and the result is narrowing of the lumen. And here we have some tumors. They are quite easy. This is a benign tumor with endothelial differentiation known as hemangioma, exophytic tumor. You see that they look like capillary vessels with a lobular configuration. They form lobules. They are benign tumors. However, this tumor here, which is highly vascularized, but with rather irregular vessels, is a malignant tumor with endothelial differentiation identified as an angiosarcoma. And here is the histology of an angiosarcoma. You see that there are some blood cells. It's not so well differentiated, so we cannot discriminate the lumens of the neoplastic vessel formations. So this is an angiosarcoma. All right. That's all for today.